the origin of bronchiectasis and how it gets worse, because every talk today fits nicely into a puzzle, which I will show you later on. Uh, So an overview of what I'm going to talk to you about, a short historical background. First, I'll go through the healthy lung and then the wide variety of symptoms within bronchiectasis. If you would put resin in the lung, and you would take the lung away, you would have this nice cast of the bronchial airways. And if you put it upside down, it looks like a tree. So you see that the airways become smaller and smaller towards the periphery, and they have a nice tubular form. It has two main zones, the conducting zones, where it mainly conducts air. It has obviously other functions as well, which we will talk about later. And then there's the respiratory zone. And if we think about how bronchiectasis originates and how it gets worse, we think about the vicious vortex. And the vicious vortex is 4 elements. It used to be called the vicious cycle, but we call it a vortex now because each of these 4 elements influences the other elements. And so we have a part of destruction of the lung, we have a part mucus hypersecretion, epithelial dysfunction, and ciliary dysfunction. We have a part inflammation and a part infection. So let's start out with bronchus destruction or deformity of the bronchial wall. Here you can see in the white a bronchus and in the red an adjacent vessel. And this is a micro CT imaging of small airways. And so normally the airway vessel, the red, should be in diameter the same as the bronchus. And here you can see that the diameter of the white bronchus is enlarged. This is what we call a bronchiectasis. So this is typically the radiological definition of what a bronchiectasis really is. The second element that goes wrong in bronchiectasis or in many patients is the epithelial dysfunction, mucus hypersecretion, and ciliary dysfunction. Those are all difficult words, but what it really means on the top left corner is that your airway walls are covered with epithelium, sort of airway skin cells, one would say, sort of the wall of the airways. And then in between you have these blue cells, which we call goblet cells that produce mucus. And on top of it, you have a hair-like structures, which we call cilia. And so these red cells, the epithelium, the wall, the bricks of the wall, so to speak, are hyperplastic, which means that their cell division is increased. There are more of them present. And by doing that, you can see that the walls lose their nice shape in a certain way. Also, the goblet cells in between are becoming hyperplastic, so more of them as compared to a normal airway, and they are hypertrophic, which means that they are enlarged in size. And the cilia, why are they there? They produce a whip-like motion, synchronous, that will propagate the overlying mucus layer. Just to give you an idea of what a healthy airway should look like. And in patients with bronchiectasis, this is changed, this is altered. And more on that on the talk of Arietta Spinu. There's also an important inflammatory problem in patients with bronchiectasis. As you know, there are many, it's a very complicated thing, inflammation, and in all the inflammatory cells. More specifically in bronchiectasis, white blood cells are very important as they, as you can see here, chase bacteria down and try to eat them. And in bronchiectasis, we see that this inflammatory response goes a little bit wrong. Here you can see the white blood cell eating the bacteria finally. In search of his next victim. But in bronchiectasis, not only these white blood cells are increased, but the substances they produce are also increased and can cause deleterious effects if it's too much. But more on that in the talk by James. And then there's the fourth element, which is the chronic infection element. On the right side, you see the mucus layer with the cilia. And when it gets infected by these small rods, you can easily see that there is a aberration and destruction of not only the cilia, but also what's underneath. And if this infection is too much, it's sometimes difficult for the body to cope with. And then you can get, as a result, for example, bronchiectasis. Now, for a short historical background, and I've seen some questions already on whether the presentation could be in French. So for those French speakers, a little bit of French, because the first person to describe bronchiectasis was René Théodore Laennec, French physician who reintroduced the stethoscope, by the way. And he says that he is the only author of which he knows that talks about bronchiectasis for the first time. Here you can see aucun auteur que je sache n'en a parlé. And he talks about the fact that these bronchiectasis acquire a diameter, a cuillère en diamètre, that is égal à celui d'une plume d'oie, like a goose plume, or even the thickness of a finger, à même celui du doigt. And he also describes very nicely, just for people who do not or who have a difficulty of envisaging how a bronchiectasis looks like when you would put it out of the body. He says that these tuyaux bronchiques, these bronchial tubes, are so much dilated that they end, se terminent par des cul-de-sac ou cellules, in little cells or sacs that are capable of keeping logé un grain de cheneville, which is a hennep seed, un noyau de cerise, which is the core of a cherry, and or a hazelnut, une aveline, or an almond. So just to give you an idea of how bronchiectasis, when you would cut it open, looks like, and what the shape of these bronchiectasis is, and sort of dimension you can imagine with these examples. Here you can see René Théodore Laennec testing his reinvention of the stethoscope. And fortunately, the last 15 years or so, we have an increase, as you can see, in publications on the topic of bronchiectasis and non-CF bronchiectasis. You can see here that the past 4 or 5 years, there's a drop in the term non-CF bronchiectasis in PubMed, which is the largest database on medical research. But that is because of the fact that we are trying to get rid of the term non-CF. As Stuart Elborn, professor in Ireland, very nicely put it, it is untenable to define something by what it is not. We should define something by what it is. So no nonsense, no non-CF. That means that we were trying, as a part of research, trying to determine the differences between the different patients with bronchiectasis, and hopefully in the future we can talk about, for example, autoimmune bronchiectasis, CF bronchiectasis, primary ciliary dyskinesia bronchiectasis, rheumatoid arthritis bronchiectasis, etc., etc. As you know, and I've just told you, bronchiectasis can present itself in a quite big variety of ways. And one of the varieties is radiologically. It has 3 main stages. Historically, these are still being used. I think they have been described in the 50s for the first time. And in the first stage, if you look at the CT scan, which is now the gold standard, it used to be bronchography, but now it's fortunately for the patient's CT, which is less invasive. You can see that there are cylindrical bronchiectasis are characterized by a, as you have seen in the 3D image in the beginning, an enlarged bronchus with a smaller adjacent vessel. A normal airway would have the same size as the adjacent vessel, and it looks like a signet ring, a ring with a stone or a diamond on it. If you would cut the tube in its length, you will have a tramline appearance, because normally, as I've shown you with the bronchial cast image in the first slide, the airways become smaller towards the periphery, but in bronchiectasis patients, the airway walls do not get smaller. In the next stage, we have varicose bronchiectasis, because they have a varix-like appearance. The tube shape is steadily being lost, and it's losing its shape, as you can see, having a sort of varix appearance. And in the last stage, we call it saccular or cystic bronchiectasis, because they have totally lost their airway wall integrity, and they have this cyst-like appearance. Not only based on radiological imaging, there's a difference between patients, but also if we look at symptoms. We have looked at all or a large part of the studies on bronchiectasis and looked at what definitions they used to include patients in their studies. And as you can see, there is a wide range of different symptoms that can be linked with bronchiectasis. And then we thought, well, all these trials are using all these different definitions. Maybe for the future, we should try to get a consensus of what would be for clinical trials at least, important in the definition of bronchiectasis, which does not mean that in a clinical atmosphere there are not other symptoms, for example. And this is obviously at the diagnosis, because many patients, when they get treated, they get better, and sometimes some symptoms disappear. But as you can see, cough, sputum, exacerbations, hemoptysis are the mainstream of symptoms in bronchiectasis, but more on symptoms in the talk by Josje Altenberg. Then we come to the definition. We have, you might ask, well, hasn't there been a definition on bronchiectasis? Well, only recently we have thought about trying to define bronchiectasis more in detail, because it used to be a more radiological diagnosis, but we disagreed with this, and we thought that not only radiology should be important in the definition, but also symptoms. And for clinical trials, we say, well, cough most days of the week, sputum production most days of the week, and a history of exacerbation at diagnosis. Then the causes of bronchiectasis. Well, the causes, again, a very big variety of possible causes. Stefano Aliberti in his talk is going to talk about this. But as you can see, some of them are pretty obvious. Post-infectious causes, viral bacterial infections, atypical mycobacterial infections, COPD, which is a smoking obstructive pulmonary lung disease. Immunological abnormalities. If you have a bad immune system, you get recurrent infections, and then you can get bronchiectasis. This can be primary, which is innate, or secondary as a cause of something else, for example, chemotherapy that reduces your immunity and causes infections. These can be congenital anatomical aberrations that can cause bronchiectasis, like tracheobronchomegaly or sequestration. There's also inhalation or aspiration that can cause bronchiectasis. As you can see, there's a very wide range of possible causes. And so calling all these different people non-CF in one and the same group seems untenable. And that's what one part of research is trying to do, trying to unravel this web of different etiologies. Just to show you how sometimes unique bronchiectasis can be. This was a patient, I think in Brazil, who had recurrent pneumonia, localized bronchiectasis. And when they operated this patient and removed the lobe, they saw this, as you can see, ectatic bronchus. And inside was something very strange. It was the etiquette of a flip-flop, Havaianas flip-flop. So this is the first bronchiectasis flip-flop or flip-flop lung, just to show you that very banal things can cause bronchiectasis sometimes. There was also a question about demographics of bronchiectasis. And fortunately, the past 5 years have been a great period, because many registries have been online. And I've taken a few registries, for example, the European one. As you can see, many centers participated. If you look at the etiology, which is the middle graph here, the circle, you see that post-infective causes and idiopathic causes are the mainstream of causes for bronchiectasis in Europe. A large part as well, asthma and COPD, and then immune deficiency, rheumatoid arthritis, ABPA, which is allergic bronchopulmonary aspergillosis. Primary ciliary dyskinesia in purple, which is dysfunction of those cilia I talked about earlier. And then GORD, which is reflux disease. IBD is inflammatory bowel disease. If we look at the demographics, we see that the European patients are mainly female, 58%, and the average age is 68 years of age. Most of the patients, luckily, have never been hospitalized, but the distribution of exacerbations is ranging from 0 to, let's say, 4 or 5 exacerbations. Fortunately, often patients have a reduction in exacerbations when treatment is started. If we look at the bacteria in the airways, because that's one of the points that Michal is going to talk to you about, Pseudomonas aeruginosa in Europe is the biggest one in about 18% of patients. And this is important. We have a very low prevalence of non-tuberculous mycobacteria, as opposed to America, for example. If we look at the Indian EMBARC database, which is also a very large database, we see that there's a difference in etiology. They have a very large group of post-tuberculosis bronchiectasis because it's more prevalent and present in India. They also have idiopathic and post-infective, which is other reasons, for example, pneumonia. They also have ABPA, but what we are missing here, for example, is we have a big group of primary immune deficient patients, and this is not the case, for example, in India. But for the rest, in terms of hospitalization and the use of oral antibiotics, so exacerbations, it's more or less the same as compared to Europe. If we put the two next to each other and we try to compare them, you see that the age in India is significantly lower. They're younger patients and much more men as opposed to the European data. Whereas in America, you see much more female patients as opposed to Europe, for example. 80% female patients. In Europe, it was about 67, 70%. If we look at smokers, much less smokers in India. However, they had a quite large group of COPD patients, probably because there is quite some indoor pollution due to indoor cooking and use of fires indoors. So the smoke there or the cooking is different in India often. In terms of severity, not many differences between both India and Europe, but you can see that the mild disease is more prevalent in India and the moderate more in Europe, and the slight lung function in India. And in terms of bacteria, the striking difference is that they almost have no Haemophilus influenza or Staph aureus, but they have a similar amount of Pseudomonas aeruginosa. And if you look at America, the difference, we have 15 to 18% of Pseudomonas aeruginosa, and in America it's 33%. So a big difference there in bacteria. And the data are not here, but non-tuberculous mycobacteria in America is also very high as opposed to India and Europe. And so this final slide, just to give you an overview of today and where each talk is fitting into the day, the rest of the day. We start with the next speaker, which is Michal Steinberg. She's going to talk about the infection part of bronchiectasis. It's a very important part because we have antibiotics, we have possible treatments that can reduce infection. She will talk about this in this next talk. Then Josje Altenburg is going to talk to you about the symptoms and trying to cut the vicious cycle. So what we try to do with treatment is cut all these arrows and try to hold down the propagation and the viciousness of the cycle, and maybe in the far future going to a virtuous cycle instead of a vicious cycle. Then Ariadne Spinu is going to tackle the mucus hypersecretion and cellular dysfunction. She's a physiotherapist, so she is an expert on the topic. Then we have, very important for us, some patient experiences. As you know, not only this day, but Michal might give some words on that because she's the chair of the working group who does patient work with the patients and projects with the patients, but we value the experiences of patients very much, and our guidelines, the bronchiectasis guidelines, were, I think, the first guidelines where patients were included as author and were part of the process of producing the guidelines. So this is just to show you how important patients are in bronchiectasis research. Then a very interesting talk about symptom approach, mainly the fatigue and shortness of breath, and how to tackle that slightly from a different angle, different point of view by Dr. Spatis. And then in the center of the vicious cycle is Stefano Aliberti, who is going to talk to you about etiological testing. As I've told you, there's many etiologies. So he will talk you which one should we test, how should we test, and give you more information on that. And then inflammation, the immune system, very complicated thing, and no one better than James Chalmers to tackle immunity and inflammation in bronchiectasis. And then with the 2020 COVID-19 epidemic, we need some words on the COVID-19 and bronchiectasis. First and foremost, how do we prevent? What are the symptoms in bronchiectasis patients with COVID-19? Dr. Gramegna is going to give you a lecture on that. And then finally, how do we organize care and how do we care with patients during this COVID-19 epidemic by Felix Ringshausen. And so I would like to give the word back to the chairs, and thank you so much for inviting me. And if there are any questions, there's a Q&A after Michal's talk.
Thank you very much, Peter. This was a